Welcome to another deep dive.
Hey there.
Imagine this. Total chaos, sirens, someone's life just hanging there. How do EMS crews, when they first arrive, how do they even start to figure out what's wrong under all that pressure?
That's exactly what we're getting into today. We've been looking through detailed EMS procedures, their documentation, the actual forms they fill out,
Right.
trying to understand that systematic way they assess patients when things are critical.
Okay, so our mission today is basically to pull out the key steps, right? The crucial things they look for from that very first moment, through checking vitals, getting the story, and even handling the really tough situations.
Yeah, including how they determine death, which is obviously a very somber part of the job. It's a glimpse into how structured they have to be when, seconds really matter.
Let's dive in then. So the sources say it starts even before they lay hands on the patient, this thing called the general impression.
Exactly. It's incredibly fast, maybe 10 or 15 seconds as they're just walking up.
Just walking up, what can they tell them?
Surprising amount, actually. Just by looking and maybe asking a simple, what happened? They're gauging, are you breathing? How does it sound? Can you talk back normally or is it strained?
Skin color, obvious bleeding, that kind of thing.
Precisely. It's a rapid check of breathing, circulation, mental state, just from that first visual and verbal contact.
And from that split-second read, they then move into something more formal.
Right. That's where the ABCDE scheme comes in. It's pretty well known.
The core idea being treat first, what kills first.
That's it. You have to tackle the most immediate life threats in a specific order. So A is airway, is it open?
B, for breathing, are they actually getting air in and out effectively?
C, circulation blood flow, controlling major bleeding.
D is disability, so consciousness, neurological stuff.
Yep. And E is exposure and environment. Check the whole body, think about heat, cold, the scene itself. They work through it methodically.
Okay, let's dig a bit deeper into some of those. What stood out from the sources? Like, for breathing, B.
Well, it's not just if they're breathing, but how. The quality. They mentioned looking for really deep, rapid breathing, Kussmaul breathing.
Right, that can indicate acidosis.
Exactly. Or, on the other end, very shallow gasps, Schnappatmung, which they note as a really bad pre-final sign.
And they use tools too, right? Like pulse oximetry.
Oh yeah, quickly. Slap on a pulse oximeter, aiming for that SpO2 level of 95% or higher, ideally.
Makes sense. What about C, circulation? You mentioned pulse.
Yeah, and where they find the pulse tells a story.
Yeah.
If they can feel it easily at the wrist, a peripheral pulse, your blood pressure is likely okay, maybe over 80 or 100 systolic.
But if they can only find it in the neck, the carotid.
That's a central pulse. It suggests the pressure might be lower, maybe only around 70 systolic. It's a quick clue.
And they're looking at the skin too.
Definitely. Pale, cold, clammy skin. Classic signs of shock. And that capillary refill test, pressing on a fingernail.
To see how fast the color comes back.
Right. Should be quick, under 2 seconds. If it's slow, that's another sign circulation isn't great.
Okay, then D for disability. You mentioned the Glasgow Coma Scale.
Yeah, the GCS. It's an objective way to score consciousness. Looks at eye-opening, verbal response, and motor response.
15 is normal, right? And lower scores mean?
15 or 14, generally no major issue.
Yeah.
But if it gets down to 8 or below, that's indicating a deep coma. Often means they need to secure the airway immediately.
And pupils.
Crucial. Checking size, if they're equal, if they react to light. Unequal pupils or ones that don't react, that can be a huge red flag for head injury. Increased pressure in the skull.
And blood sugar check too, you said.
Always. Because low blood sugar can look so much like a stroke or other neurological issues. It's a simple check that can change everything.
Okay, so they've done the initial ABCDEs, stabilized immediate threats. Then they need the backstory.
Right, that's the anamnese, basically gathering history. They'll talk to the patient if they can. That's eigenamnese.
Or if the patient can't talk, they ask family, bystanders.
Exactly, from the anamnese. And they often use a structured approach for this too, like the sampler schema mentioned in the docs.
Sampler. Let's see, S is symptoms.
Yep. A, allergies. M, medications and the sources. Really stress grabbing the actual pill bottles or packaging if possible.
That's a practical tip. P.
Past illnesses. L is last meal, but also other habits. E, events leading up to whatever happened.
And R.
Risk factors. Things like smoking, heart conditions, stuff like that. It just helps them quickly build a picture.
And all this information needs to be recorded, obviously.
Absolutely. The Einsatz protocol, the incident report, it's not just paperwork. It's vital for communication with the hospital, for legal reasons, quality control.
And that leads to the handover, the Übergabe at the hospital.
Yeah, a really critical moment, often in a busy ER. They need to concisely tell the hospital team who the patient is, the main problem, key findings, brief history, what they did, how the transport went.
And for really bad cases, they call ahead.
Pre-notification, yeah. So the hospital can have the right team, like a trauma team, ready and waiting.
Okay, let's shift to the most difficult part you mentioned, determining death.
Right. It's important to remember the final declaration is a doctor's job. But EMS needs to recognize the signs to know whether to start or continue resuscitation efforts.
And the sources make a distinction between uncertain and certain signs.
They do. Things like no pulse, not breathing, totally unresponsive, fixed pupils.
Yeah.
Those are actually considered uncertain signs on their own.
Uncertain. Why?
Because of that AEIOU caution they mentioned. Conditions like severe alcohol intoxication, electrocution, injury, like head trauma, opiate overdose, or severe undercooling, hypothermia. These can sometimes mimic death. The person might still be savable.
Ah, I see. So unless there are definite signs.
Unless there are certain signs, the rule is absolutely life before death. You always attempt resuscitation if there's any doubt at all.
So what are the certain signs then, the ones that are unmistakable?
Two main ones, lichen fleck or litter mortis. That's the purplish pooling of blood in the parts of the body lowest to the ground. It starts maybe 30 to 60 minutes after the heart stops.
Okay, and the other?
Lichen star, or rigor mortis, the stiffening of the muscles. That usually starts setting in around 90 to 120 minutes after death.
So if those are present, resuscitation efforts generally aren't initiated.
Correct. And if they encounter a death where things seem off, maybe suspicious items around, signs of a struggle, they have to treat it carefully, involve the police, and preserve the scene. They also classify the manner natural, unnatural, or unexplained.
Wow. Stepping back from all this, it's just incredible, the sheer range of things they have to assess and do, from that first 10-second glance to using scoring systems, getting history, documenting everything, the handover, and then this solemn responsibility, too.
It really is the mental processing required, the structured thinking they have to apply, often in really chaotic, high-stress environments. It's immense. Accurate assessment under pressure is truly life and death.
It makes you appreciate that structured approach even more, doesn't it? How they bring order to chaos. So, thinking about everything we just covered, that whole systematic process, what specific part of it stands out most to you? What feels most critical?